Okay, thanks everyone for joining me. My name is Sherry Coswell. I'm a certified clinical hypnotherapist, registered respiratory therapist. I hold a certification in respiratory education. I'm a registered polysomnography technologist and certification in clinical sleep health. What I'd like to speak to you about today is basically how PTSD impacts sleep. So objectives. This is a really interesting topic. It's something I've always held a lot of interest in. I had back in my pre-respiratory days, I did some work as a first responder on an ambulance, and and then also working after that in acute care in the hospitals, just understanding a little bit about how trauma impacts people. And then a little bit later in my career, just understanding the mechanisms and role of sleep. And I think it's poorly understood. And once you kind of understand how sleep generally works, then you can a little understand more what it is that is uniquely you and what it is that you may need to have investigated. And then we're also going to look at the characteristics of sleep and PTSD together. And then, of course, I can't give you all of that and not give you something to address that with. So I focused on, there's many techniques that go into treating sleep that is impacted by PTSD. But mindset and breath work are one of the continuing components that we see in therapies such as cognitive behavioral therapy. So I'll go a little bit into that. So what is post-traumatic stress disorder? So I always go by the American Psychological Association when I look at anything in mental health. They usually have the most up-to-date sort of definitions and grouping of conditions under the specific orders, and for a reason, because as we go ahead with time, we understand a little bit more how these disorders are disorders and how they impact people, and we readjust accordingly. So basically, the APA is looking at this as a disorder that may result when an individual lives through or witnesses an event in which they believe that there is a threat to life or physical integrity and safety, and they experience fear, terror, or helplessness. So I think the key ones in here are may result, and it's because not everyone who witnesses or hears about trauma is impacted in the way that someone who develops PTSD might. So and the other thing that came up for me too here was an interesting piece, was that it may occur secondhand. So when you hear about a loved one who was in danger, or you hear or have repeated exposure, such as in EMS. So it may not be that EMS workers might feel that they are, at risk at all, but when they have repetitive exposures to the actual concept of trauma, then we do see that some people can develop PTSD. There's subtypes of it. So of course, the chronic PTSD, and this is the typical one. When people talk about PTSD, this is what we're talking about is chronic, which the symptoms persist for greater than 3 months. And then delayed PTSD. And I think this one has most likely missed a little bit more often because the symptom onset is 6 months from the event. And then, of course, it's been moved, instead of an anxiety disorder, which it previously was, it's been moved in the DSM-5 under trauma and stressor-related disorder. So what is trauma? I think we all have an idea what we think trauma is, but it's, I think, for the most part, quite a unique, and it's a perception-related thing. So you have to perceive that your life is being threatened in some way. And it's either through an event or an experience. It can be primary, like I said, and secondhand or repetitive in nature. And then, so what's the effect? So it's basically what we see is that these post-traumatic reactions are dependent on the degree of resiliency that people may have. And in some cases, those are innate in individuals. And then, of course, there are learned tools for resiliency as well. And generally, these reactions are short-lived, so it's less than 1 month. So in that case, we would call it an acute stress disorder. Past 4 weeks, we call it PTSD, or the chronic form. So what are the symptoms that we look for? So typically in the DSM-5, I liked the way they went about this. They went into core symptom clusters. So, one of the things that we see with veterans, and that would be recurrent, involuntary, and intrusive recollections of the event. So these memories that all of a sudden will surface, little bits here throughout the day. Now, that's different than a flashback. Flashback is a little bit different. I'll get into that later. The other thing we see is avoidance of stimuli that might be associated with trauma. So people who have PTSD would be very aware of what their triggers are. Negative alterations in cognitions or moods associated with the events or numbing. So basically, this is a shutting down that happens, and typically a mechanism of dealing with the extreme height of emotions that people with this experience. And then, of course, alterations in arousal and reactivity. So it's this heightened sensitivity to this potential threat. And of course, when they last less than 4 weeks, it's just this acute stress disorder. So statistically, this was an eye-opener for me. So if we look at lifetime prevalence, so about 6% of American adults, so over the age of 18, will experience PTSD at some point in their lives. Of those adults, women are 3 times more likely to experience it compared to men. And there is when you look at sexual trauma, that sexual trauma is more likely to produce symptoms or a diagnosis of PTSD compared to other forms of trauma. And typically women are more exposed to sexual trauma than men are. And first responders, this is an interesting piece too. So 30% of first responders have mental health problems such as PTSD. So this wide range of mental health challenges that they can deal with, one of them being PTSD. Only 10 to 15% of those 30% are diagnosed with PTSD. Now, they say more than 80% of first responders go through traumatic events while on the job. I don't know. I think that's very conservative. If anyone's worked in acute care, I'm sorry, it's a daily thing. So physical changes of PTSD. This is, I love the brain. The brain is such an incredible organ from my experience. When I used to work at the sleep lab, just watching what it could do, it's incredible. So when you look at what happens with how the brain responds post-trauma, we get some changes in a couple of key areas. So hippocampus is one of the main ones. So this is one of the main centers for memory storing and for quick, easy retrieval. So what we find with PTSD is that there's a disrupted time and place tagging of memory. So in essence, when we experience something, the hippocampus will tag that event that you've had with a specific, like a stamp, like a time and date, kind of like your phone will do for you sometimes. Now, if that's disrupted, now we get what we call a flashback. So in other words, when that memory from the original trauma comes back up, it doesn't have a date and time, place stamped onto it. So the person is going to experience that memory as it is actually happening in real time when it is actually not. And then there is, of course, the intrusive memories, which is just this disrupted storing of fragments of memory. So, and those come up as intrusive memories. So they have a time and a place attached to them. It's just they weren't stored just right. So it's almost like the brain is trying to bring these memories up. It's like, can you please sort these out? Because this isn't stored right. And so these intrusive memories will keep coming up and they can disturb you. Now, that's really important to remember in terms of how this impacts sleep. So keep that in mind. Somatic memories, it says flashbacks of physical sensations. So people who have PTSD, when they go into this flashbacks, they actually will physically feel the sensations of that event. I mean, that's profound, where the brain is actually engaging the parts of the sensations that tell you that this is happening now. The amygdala, it is changed in that it has no ability to distinguish between the memory and the real-time threat. And it has an increased secretion of these neurotransmitters, so the norepinephrine and serotonin. So you are ready to fight and flight. So it's always pumping out these fight flight hormones that just kind of always have this person primed, always sort of on the edge. And then, of course, the heightened activity in the prefrontal cortex. So I didn't see in the literature if this is a result of the amygdala hyper response, but the prefrontal cortex is in a heightened response as well. And then in that case, this is where our regulation of emotions happen. And when that is heightened, we're getting those high emotions. We're not getting the calm sort of emotions. We're getting the let's fight, flight. So the result you can imagine is anxiety, hypervigilance, so always ready to go, and an attempt to resolve the past. Let's just kind of get a resolution. Let's find an answer to what happened. So I want to go a little bit into that. So this subjective activity experience of brain activity. So when you were looking at the EEG of people, the brain activity of people, we're looking at different frequencies and amplitudes of that, and specific sort of key markers that we notice: high beta, that make it high beta, low beta, alpha, alpha theta, theta, delta, gamma. If you look at this from the top to the bottom, the high beta is your fight flight, and the gamma is going to be your monk who has been training to meditate for years and years. The doorway to sleep is alpha. So we'll also see this with people with meditation and super calm. They're maybe listening to music, things like that. But keep that one in mind. So when you look at what works for you in any given moment, so the intention is really important. If you have no changes from trauma that are happening with your brain, then you are, for the most part, aware of the thoughts that are happening in your head. You have an intention of what you would like to be in the moment. And so let's say you are sitting at home and you're comfy on your couch and you're watching TV, then the thoughts are, and the intention and the expectation is that this is rest and digest mode. So the intention, just those thoughts, are going to create this cascade of effect that puts you into parasympathetic or this rest digest mode. If it's the opposite, where maybe you're in traffic and you're 5 minutes late to get somewhere, you're in sympathetic mode, you're in fight flight. So of course, these thoughts and this brain function determine which is going to be predominant. Someone who has brain changes from PTSD isn't going to have full control of those thoughts, because those intrusive memories, those flashbacks, and this heightened activity in the brain that is always trying to keep it in sympathetic mode is always on. So we have this, addressing this issue is where we try to bring in awareness for people. And that's going to come in a bit later with the breath work. So what's anxiety? Because this is the underlying feeling that we get when we experience the symptoms of COPD. So anxiety is an emotion. So it's characterized by feelings of tension, worried thoughts, physical changes. Keep in mind that anxiety and fear are very, very different. Anxiety is a very diffuse fear, and it's future oriented. And so it isn't any one particular thing. It is imagining several different scenarios that might happen in the future. Fear is a present oriented or past sort of thing, but it's usually quite present and short-lived response. So we're in that fear about 5% of the time. Someone who suffers from anxiety or anxiety-related disorders are in that anxiety feeling about 95% of the time. We're only meant to be in fear 5% of our time. So the APA clinical guidelines for treating PTSD, they have 4 strong recommendations and 4 conditional ones. And I think a lot of people, we hear a lot of this, these interesting therapies like the EMDR and tapping and the narrative exposure therapy, and of course some of these medications that come in, because those are more sort of on the horizon. They've just kind of come into play not that long ago compared to these concepts of cognitive behavioral therapy. So the 4 strong recommendations, the top 3 are all varying forms of cognitive behavioral therapy. And the last one, of course, is based on cognitive behavioral therapy. So knowing all of that, what can go wrong? What should be right? So this is where a lot of people kind of get a little bit muddled, where what is normal sleep? Some people go, well, I do great on 6 hours, and I do great on 10 hours, and I do great on 7 hours. If you look at all the different factors that can influence what is normal, you look at age, because we expect babies to be sleeping your 10 to 12 hours. We expect someone my age and in the middle range to be doing that 7 to 9 hours. So what is normal? Culturally, of course, that's going to change it. If someone who is closer to the equator, they're going to be sleeping shorter times at night, and then again a longer nap time during the day, and they're going to do it into bigger chunks because that is tied to their sun, and we'll go into that a little bit later. And then of course demographics and geography too. So if you look at all these factors, duration is influenced by most of these factors. So the American Academy of Sleep Medicine is the benchmark that we usually use when we look at these things. And they say to support optimal health in most adults, we're looking at 7 to 9 hours. That's about 80% of our population. You've got 10% on the lower side, and you also have your 10% on the higher side. And those people are also going to be normal. So this is my favorite part. I'm passionate about sleep. So sleep is like a dance. So if you were to look at somebody in a sleep lab who was sleeping, we have them all wired from head to toe. We've got an EEG running. We're looking at their heart. We're looking at their breath rate. We're looking at the muscle tone. So many different factors. And we're looking for 80 plus sleep disorders when we're looking at that. Anything from parasomnias to movement disorders, all different types of things, breathing disorders. But what we look at first is the sleep architecture. We do about, in a study that runs from about 8 hours in length, 7 to 8 hours in length, we will get about 900 to 1,000 pages of data, 30-second pages of data. And on each one, we will stage it for a specific stage of sleep. And these stages of sleep are really important because the brain has to transition through them. A normal brain transitions through them in a certain way. So a brain that is not affected by anything else, trauma or anything else related, it is going to start from awake at the first part here, right here. And then it's going to go down to N1 briefly. This is a transitional stage. Then quickly through N2, depending on your age. The older you get, the more you spend time in stage N2. But then we go into N3. So this is considered deep sleep. And you'll notice how we only have N3 sleep in the first half of the night. This is where it predominates. This is where we get growth hormone and all these sort of memory processing and rest and regenerate factors. So when your mom says go to sleep because you got a cold, that's what she's talking about. If you go to the second part of the night, you'll see what we have with this REM. So in this first cycle right here, this is one cycle from here to here. And we go from wake to N1 to N2 to N3 and all the way back up to REM. Look how short that is, 5 minutes. That's totally normal. The first REM stage, very, very normal. And then it increases throughout the night, say longer and longer. And then towards the end of the night, you'll see it kind of interrupted a little bit at the end. Typically, these REM stages increase. So when we expect to see a brain that is not sleep deprived or not having any issues, we should see it look like this on a sleep study for an entire night. So what is the progression of consciousness falling asleep? Remember with that brain activity I was talking to you about as you were awake, we get the same, slightly different, but falling asleep. So we've got this alpha wave activity here, this closing the eyes, cleansing breath. High beta is, of course, your fight flight, or you're ruminating, you're worrying about things, you're planning, that sort of thing. Low beta is quiet conversation. Alpha activity, that's your last little, when you do that sigh, you sit in your bed and you close your eyes, you're going into alpha right there. And then sleep is this alpha theta border. This is that non-REM. Theta wave is N2, delta activity N3, which I was talking about with the growth hormone, and then theta a mixed theta, of course. All of these are mixes. This is like a broad sort of categoric look at sleep stages. This is one of my favorite pieces of sleep, and this is where it is so important about how PTSD impacts us. So we dream in all sleep stages. A lot of people think that we only dream in REM. So if you look at this side here, this librarian that is filing books and such, and then you look over here at this child using their imagination. Imagine the left side with the librarian. That's all your non-REM sleep. So you're doing a quick, easy, retrievable sort of filing of everything. So you're organizing all of the things that you were exposed to during the day. That's what your non-REM sleep is supposed to do. They are boring dreams. However, they're really important for body repair. If you look at REM sleep here, this is also brain repair. This is brain repair as well, processes emotion, helps consolidate memory, but they're saving your world dreams. Some of the studies that they've done on what happens with the brain in non-REM and REM is in REM, we see a dump of these proteins that accumulate between the neurons in the brain. If we don't have REM, we have people with dementia type symptoms, similar to what we see in Alzheimer's. It doesn't mean it's Alzheimer's, it means it is Alzheimer's-like. So some of the key things that we understand there in this case is if you can't make those connections, you don't have long-term memory. So this is what's really important between stage non-REM 3 and REM sleep. And, you know, these waves of the cerebral spinal fluid that's washing the brain in that stage sleep, so important to keep that brain fresh and unimpinged so it can make those connections and find that data that you were exposed to the day before so you can remember what you wanted to say to that person standing in front of you. So sleep after trauma. So the problem is that when you have a focus on possible future threats that you don't know where and when it might happen, they might just pop up anytime, and there's no estimate of resolution, you're stuck in some sympathetic tone. The other thing that comes up, and this is a thing that I saw in the sleep lab quite often, I'd have people that would come in, sleep all night, and they'd show me central apneas all night. And so I'd ask them when they wake up during the day, say, hey, do you notice you hold your breath during the day or you forget to breathe? And they go, yeah, how did you know? And it's because what we do during the day, we do at night. So it's these underneath these patterns that we have, these automatic patterns that happen, these subconscious things that we do to kind of make everything the same. We like to match things. We like everything to be as one. So flashbacks in the daytime come back as nightmares at night. So, and of course we get non-restorative sleep and it's interrupted. So why do we have non-restorative sleep? If you look at the sleep pattern, and this is kind of a beautiful picture of alpha intrusion. So typically what you would see in a brain pattern here, this is actually some REM, but it's got some alpha intrusion happening. So you can see some really fine details happening here, this little squiggly lines that are happening on top. You see how here it's a little bit less fast, it's slower, and then it speeds up quite a bit right here. This is alpha. This is what helps a person with PTSD maintain a little bit of wakefulness, that easier to rouse, that easier to wake to anything that might be threatening them in the environment. What's the result? They wake up many, many more times. And then they also have insomnia periods where their brain is saying, you were awake. It feels like they're awake, but they are actually sleeping. So it's really hard to convince somebody here that they were in REM or that they were even in stage N3 sleep because they never feel like they're deep because their brain's telling them we're putting some wake on top here to keep you ready. So of course, the sleep fragmentation ends up in insomnia. And then of course, the nightmares we were talking about. So what's insomnia disorder? A really good idea to get a little bit more familiar with exactly what we talk about when we talk about insomnia. Everyone thinks, I just can't sleep, but what does that look like? So it's defined in the International Classification of Sleep Disorders, number 3, as a complaint of trouble initiating or maintaining sleep. So you can't fall asleep or you can't stay asleep. and it's associated with daytime consequences. And this is not attributed to how you've set up your sleep environment or the fact that you went to bed too late. That is not insomnia. That is behaviorally induced insufficient sleep syndrome. That as actually a sleep disorder. It includes both acute and chronic insomnia. Chronic is 3 times a week for at least 3 months, and of course, acute is less than that. And you see things like daytime sleepiness and fatigue, and we actually see decreased immune function with people who suffer from insomnia. And of course, because this isn't intact, or those sleep stages aren't intact, we're not cleaning out the brain properly. So we have impaired cognitive processes, and we have things like depression and anxiety, because try trudging through a brain that's clogged up all day, every day. That's exhausting. And of course, those memory deficits, you're not making those connections. So what are the things that keep you awake? We already talked a little bit about the PTSD. If you look at fear, basically the end, this finality of things that are life-threatening, that's a big one. The other one is exposure to the eyes to light. We'll get into that a bit. Circadian rhythms, physical activity, diet, and then of course, doing things in bed that you shouldn't be doing in bed. So this is the central clock of the body. So if you want to talk a little bit about what influences your pressure to sleep, we're looking at our central clock and all the things that influence it and all the things that it influences. The biggest influencer of this central clock, which is in the suprachiasmatic nucleus, it's in the middle part of the hippocampus. It is directly attached to the eyes. So you get this, when you get exposure of light, then the SCN produces serotonin. That influences these other peripheral clocks here, the heart and the liver and the cells down to the cellular level to say, oh, it's daytime. We need to be metabolizing, we need to be digesting, we need to have our heart rate, we need to change our blood pressure accordingly so that we can do these things like activity. Now, if you don't have exposure to light, the central clock is going to secrete melatonin. That tells all of these other clocks, oh, this is bedtime. So now we're going to slow the heart rate, we're going to slow the digestion, and everything's going to slow down for the night. If you were to get up during the middle of the night because you think, oh, I'm not sleeping, and you decide, you know what, I'm kind of hungry, I'll go have something to eat. Guess what you're doing to your liver, to the clock in the liver? And then let's say you decide, I'm just going to go for a walk. Maybe I'll go outside. What are you doing to your heart rate? Oh, guess what? It's time to be awake. Both of those get influencing back onto this master circadian clock. And it's like pushing the needle back or ahead. You're jet lagging yourself. So there's lots of things you can do by being aware of what your influence is on your internal processes and how these things like food, body temperature, your activity levels, and especially light, the biggest Zeitgeber or the influencer on the internal circadian clock. So that leads me to this gut brain. So I think this has been out there in the literature a little bit. So we have basically 500 million neurons. They work independent of the brain. They basically are all over the gut. They produce 95% of the serotonin, this happy hormone. And that they also link up directly into this vagus nerve. And that signal goes mostly one way from the gut up to the brain, not the other way around. It controls the activity of the brain with the serotonin and the vagus nerve accordingly. And then, of course, there's the heart brain. The heart has 40,000 neurons that also work independent of the brain, and they control the electrical activity of the brain chemically and electrically. There's a really interesting study out there if you want to have a look for it. Basically, they took some participants and they blindfolded them and they put pictures in front of them, and these were either disturbing pictures or really happy pictures, and without any sound or sight or texture, anything for the brain to get any information on what was there. They found that the ECG changed as soon as they changed the picture. And then the person noticed, okay, there's a change happening. So what they found is that intuitive information, these neurons somehow are detecting this. And of course, they have no idea why. So this is all pretty new stuff. So sleep management for PTSD. So if we take into account all of these clocks, all of these things that we're looking at for how we want to manage sleep, what you want to look at is how regular are you going to be? So you can manage those things when you eat, when you decide to go to bed, and keeping those as consistent as possible. The other thing is creating a sleep conducive environment. So you would think that this is an easy one to do, but it wasn't just once that I had to pull a chocolate bar out of someone's hand as they were climbing into bed in the sleep lab. So keeping your bedroom cool, dark, quiet, and it's not a place to do anything else, not eating, not exercising, sleep, or sex only, so that your perception, your intention, your expectations of that environment for your brain, for your body is going to be, this is a place of rest where I get to recharge. And then, of course, there's practicing good sleep hygiene, so diet, exercise, and then creating that set and setting. Limiting your naps. This goes back to your influence in the circadian clock. You're going to create this little jet lagging happening if you don't keep it short and earlier in the day. And if you've set up everything else and you think you're doing everything right and you're still suffering from some chronic sleep issues, you're for sure going to be seeking some professional help, speaking to your family doctor, getting referrals to a sleep physician, and going from there. So this leads me back to the American Academy of Sleep Management, American Academy of Sleep Medicine, Management of Sleep Disturbances. So the very first thing that they always do is addressing current sleep hygiene practices. So bringing attention, of course, to the timing and the quality and quantity of sleep. They like that 7 to 9 hours, and they want to know that you're not eating in bed and you're setting up a consistent and reliable routine. And then they also look at cognitive behavioral therapy for insomnia, or CBTI, for education. So education is everything. So when you understand about how your body works, these internal clocks, these influences from the outside, and how some events in your life can change your perception and can change how the internal processes work, then it's easier to implement the things that work for you, because there's all these hygiene practices, but you're going to notice the key things that work for you, and you're going to create what works best in your situation. And then also, from both sides of the spectrum, we want to encourage activities that alleviate the stress load, that kind of help you de-stress, right? And then you're also setting yourself up for looking for this optimal hormonal pressure that is going to help promote this good sleep, and minimizing all of the barriers that you previously put in front of good sleep. So again, CBTI is the recommended therapy. It's a first-line treatment, and behavioral therapy for insomnia is the alternative. It's shorter. It's a shorter program. It's usually easier to access, and it's cheaper. So we usually see behavioral therapy come into play quite a bit as opposed to the CBTI. The CBTI is typically more successful, but the BTIs in a real world situation is better than nothing. And of course, the behavioral therapy can involve things like stimulus control and relaxation therapy, and of course, education around good sleep hygiene. This is one of my favorite things to teach people about sleep. So when do you stop certain things? For people who have insomnia or have difficulty initiating sleep, 10 hours before bed, stop drinking caffeine. This is the minimum. If you are a person who's quite sensitive, then I recommend looking at, should you have caffeine in your diet? It can be challenging, but it's doable. 3 hours before, you want to stop eating and drinking alcohol, because you are influencing those internal clocks in the gut, in the liver, and you're telling your body this is wake time. So you don't want your liver metabolizing while you're sleeping, because it's supposed to be resting, and it's going to be stimulating you to be awake if it's trying to either metabolize alcohol in the second half of the night or the food in the first half of the night. 2 hours before stop working, we want to get you out of beta. We want you in this calmer state. We want to be starting to kind of click down into these lower parts of sleep that help you transition from wake to sleep. And then 1 hour before, avoiding screen time. I actually think it should be higher, but in a real world, and to expect this of people, 1 hour is actually a big ask when you think about the availability of the cell phone and how people get a hold of you and things like that. But avoiding screen time, and that's just purely for the light, but also depending, like, what else are you doing with that screen time? Is your teenage child pushing your buttons, and then now you've got that stress or that extrinsic stimuli. And then 0 times you should hit that snooze button. Oh my gosh, so many times people hit that snooze button in the morning, and that just messes up that REM sleep. Remember that REM sleep that's concentrated in the last part of the night. Every time you go to fall asleep again, you can slip right back into that REM really, really quickly, because that's where it predominates. And then to be pulled out of that again is just torture. Don't do it. So again, sleep hygiene, this should be really, really easy stuff, but how much of this stuff do we actually do for ourselves? So things like subtle stretching, there's some interesting literature out there on subtle stretching, and Body Keeps a Score. It's a book by Bessel van der Kolk, and he's a Dutch psychiatrist who's done some interesting work on how the body keeps the score, his theories there. And the subtle stretching, as it relates to just stretching or yoga or things like that, just releasing the tension in the muscle fascia. And we find that people can, as their body physically slows down, the mind physically slows down. Taking a bath, it's one of those weightless warmth kind of feels. It's that tactile thing. So notice what works for you. Supplementation is really interesting. So metabolites like magnesium, calcium, etc., they can help support healthy sleep cycles. Everyone's different on how they react to things like that. And I always talk to people about, if they're looking at supplementation, that they, have a good chat with their doctor about, what might work for them, and what's the highest they should go, what's the lowest they should go. And of course, the things like tranquilizers, etc., they can be helpful in some situations, but they often will suppress REM or deep sleep. So we're not getting that clean out of the brain, or it's getting pushed back into the very end of the night. And so people may not wake up as much, but they don't feel rested because they're not cycling through the sleep cycles like they should. Listening to calm music, it is tuning the brain. You are basically using it as a tuning fork to get yourself into alpha. Now, again, if you listen to rock music or like heavy metal, you're high beta. It's meant to get you psyched up. If you listen to other tones like meditation type music, or if you even type in alpha music into YouTube, you'll find all different kinds of alpha music. But the whole point is it helps the brain align to a calmer state of being. And then, of course, lots of meditation apps. The lighting, of course, the number one. So build your routine. Make sure, don't get stuck on these rules. Make sure you look at what works for you. Looking at all of these things, you can kind of see what sticks out for you. Start there. The biggest thing that stands out for you, and if you can do one little thing to change it, and I like that, like what Albert said about the CPAP in that case, that you do that 5 minutes. It goes back to Atomic Habits of James Clear. You just do this one little thing. That's how you get to the gym. You put your shoes in the trunk and you drive around with your shoes in the trunk for a week. And then maybe you get to the front door and you get there and you're in the gym for 5 minutes, and you're only allowed to stay 5 minutes, and you got to leave. So it's the same thing. It's these tiny little things that show, but you pick the one that stands out for you here, and that's where you start. And then you can start kind of whittling away about all the different things that you can do to change your sleep. But find your recipe. And remember, It's okay to have a bad night. We are human beings. Oh my gosh, we are human beings. And anyone who's gone through any trauma, your brain is helping you by going through these memories and bringing them up. And it's going to impact your sleep for the first little bit of the night. But some of these tools are going to minimize how much that impacts you so that you can hopefully try and work through that a little bit, depending on your situation, whether you do it with a professional or it's something that you're feeling you need to do on your own at the moment. So again, the CBTI is our gold standard for how we treat insomnia. Its focus is on the thoughts. So we put all of our focus on changing the thoughts, reframing the thoughts. So based on the idea that the way you think and then subsequently how you feel about something can affect what you do. So this is your perception. Okay, and of course, stress leading to uncharacteristic decisions and calm leading to characteristic. Now, understanding stress is in that fight flight. You're in react mode. You're not thinking through, you're reacting. It's not all of who you are. Calm is more aligned to the person that you are. And so you're using all of your resources, your scope, your perception is very wide ranged, and your resulting decisions are very characteristic and balanced, and the outcome accordingly. So stimulus control therapy, again, do not do anything in the bedroom that is not sleep or sex unless you don't have any issues at all. So it is a slippery slope, though. If your sleep is great and then you get kind of lazy with it, it can creep up on you. So it's just a bit of a word to the wise. So what stimulus control therapy kind of brings that concept in and encourages you that you only go to sleep too when you're tired, so that you have that cue. Okay, I'm tired, right? What happens next? Yeah, I go to bed. So that anytime you're tired like that, you understand that, yeah, I'm just going to go to bed. And then now this is where I only sleep or for sex. So the difference between this mind-body connection and CBT, and this is kind of where we go a little bit in the hypnotherapy world. So the mind-body connection is this mental and emotional health can impact physical health and vice versa. So it puts equal strength on the mental and the physical, so the cognitive and the behavioral piece. Whereas CBT primarily targets the cognitive processes, so the thoughts, and acknowledging that changing thoughts can lead to changes in emotions and behaviors and perhaps the physical well-being, but the focus is on the cognition. Now, to understand, knowing what's happening and being aware, these are the starting points of conscious and creative thoughts. So as opposed to reacting, now you're thinking things through, you're understanding about how you're ticking and what's happening, and now you're aware of, oh yeah, I react like this when this happens. Now you can be creative in reacting. And that's conscious action. That is the act of thriving. When you react, that's just an unconscious reflex for survival. That's why it's only supposed to be 5% of our existence. The healthy mindset is a balance of both. Where do you think PTSD puts you? It's going to put you in reaction. That's not who we are. So what do? We look at some other therapies as well, like relaxation therapy. And this is part of that behavioral therapy that I was talking about, that BTI. And so there's a couple of different ones that we'll look at. There's a somatic tension reduction and there's a cognitive arousal reduction. So the somatic tension is going to focus on how we relax the body. So we use a progressive muscle relaxation. So you've probably heard these things be back and forth where you they ask you to relax, and starting from the top of your head and imagining all the way down to your toes, or maybe tensing something up and then relaxing it. That's somatic. Cognitive arousal reduction is like meditation, guided imagery, training, hypnosis, things like that. And of course, hypnosis is like the next level of that, where we're dealing more with subconscious and less with conscious. So depending on one's suggestibility, and this is basically how you relate to the world, whether you're a read between the lines kind of person or you're a real literal physical person. we will choose one over the other. And this is where the psychologist will determine what works best. And sometimes they do a combination of both. But people with PTSD and attention deficit disorder, they need that guidance through all this. They can't do these things on their own. They get stuck. They do certain things. So what happens when you do this sort of work? And what happens when you go through trauma? You get a particular mindset. So what is a mindset? APA says it's a state of mind that influences how people think about and then enact their goal-directed activities in ways that might systemically promote or interfere with optimal functioning. So again, it could be positive or negative. Mindset isn't just a positive thing. So PTSD, it's fight, flight, be ready, hypervigilant, I'm going to keep you safe. Sleep is the opposite. So imagine now a mindset on opposite end of the spectrum. How do we bridge that gap? How do we bridge it? We train the brain. So we train the brain. When we train the brain in high beta, when we're always hyper-focused, right? Hyper-focused, we have this increased focus, increased alertness. You're going to survive. Well, you're going to be ready for anything that comes around the corner. Low beta, you are focused. You're calm, but you're focused. So you're studying, you're taking in your attention. Alpha is that beautiful sort of doorway to sleep. It's this inner awareness of self. You just got this beautiful mind-body connection, balance going on. And then, of course, alpha theta borders, this abstract thinking, self-control. We use this with neuro-linguistic programming. And then we have the theta wave activity, which is your subconscious world. So it's drifting, trance-like state. Delta wave, this is that stage 3. We'll see that in sleep, and we'll also see it in very deep meditation. So mindset generators, how do we generate a mindset? So again, meditation, visualization. How do you set that intention? What are we going into this with the intention of? Someone with PTSD is going to go into a situation with the intention that this could be a threat. There could be a threat. And that's what the intention is that they're setting, because this is what is happening with their brain. Someone who is expecting to go into sleep as a calm and restful, regenerative, safe place, they're going to have a good sleep. So if you look at things like mindfulness practices, like present moment, and then physical activity and breath work, internal dialogue, external environment, all of these things can change the way you develop that intention and that resulting mindset. So I love this saying. It's corny, but I love it. Where your focus goes, energy flows. So I use this all the time when I teach people diaphragmatic breathing. And if you don't put your focus on your diaphragm, you're not moving it properly. Yogis know this brilliantly. And I think the very first time I was taught effective breath work was by a yoga teacher. It was pretty amazing. But basically, when you look at where you put your focus, this is what you're empowering. So if I put my focus on my diaphragm, I'm empowering that. If I put my focus on a good sleep, I'm empowering that. If I ask people what they want out of a good sleep and they say, I just don't want to wake up 2,000 times tonight, Sherry. And I'm like, okay, well, if that's what we're focusing on, that's what we're going to get. That's what your subconscious takes. So whatever thought you have creates the resulting hormones, going to create a resulting emotion and then body response. And overall, we're going to create this response to the environment based on that original thought, which is why we bring CBT in quite a bit. So what is hypnosis? I love hypnosis because we are dealing with this subconscious piece. We go a little bit lower, but when we use hypnotherapy, we are using cognitive-based approaches where we're looking at reframing the thought, not replacing the thought. People come to me all the time saying, help me quit smoking. I want to not remember or not do this. I'm like, okay, that's brainwashing. We don't do brainwashing. Hypnosis is about, or hypnotherapy in general, is this, bringing you into the state of consciousness where you can have this focused attention, reduce peripheral awareness. We're bringing all your focus in, and we're increasing that capacity for response to suggestions. So people are more open to suggestions of possibilities. And we go in with the intention. We always understand that people have an intention before they go into this, because if they don't have the intention going in, it's simply meditation. And we're just getting calm out of it. And everyone has been in a level of hypnosis through intensely focused activity. If you drove home and then you forgot how you got from A to B, that's hypnosis. If you've been daydreaming, that's hypnosis. The brain does this all the time, where it clicks off for a moment. Your outside body is running on subconscious programs, driving your car, telling your kids do this or that, and daydreaming while you are working on subconscious pieces underneath. So again, progression of consciousness. So hypnosis or meditation, this is relates to how we fall asleep. So for beta wave activity, we have these, progressive, the somatic exercises, and we can kind of bring people down from this high beta to the low beta. And then we have the alpha wave activity. So basically, we can do things like neurolinguistic programming and great space for concentration, alpha theta borders, where I do a lot of hypnosis, hypnotherapy, imprinting, and timeline therapy. And then theta wave activity with our complete subconscious. This is the goal, to be going from here to here, beta to theta. So what does breath work do? Breath work is that beautiful behavioral therapy, in that it gives you that mind-body connection. It puts you back in touch with your body in the present moment. If you think about anxiety, remember, anxiety is future related. We want to be present moment in a state of calm, checking in. We are here, we are now. So hallmarks of insomnia: difficulty falling asleep at night. What does breathwork do? It facilitates that shift in the central nervous system tone from sympathetic to parasympathetic. If you were to take 3 long, easy, deep breaths with a slight hold on the inhale and then long exhale, double the time on the exhale than you do on the inhale, 3 of those breaths and you're in parasympathetic tone. I don't care where you were before, it kicks you down into parasympathetic tone through several different processes. Waking up frequently during the night. So if what you practice during the day, getting you into parasympathetic tone, it will result in a solid sleep. Also, using it anywhere, anytime. If you wake up too early, middle of the night, you don't want to be getting up and, doing exercise or eating something. You're going to be throwing off your internal clock. So breath work allows you to stay in bed and allows you to focus in and just breathe, engaging the central nervous system to work for you this time and not to you. Daytime fatigue and sleepiness. So when you have more parasympathetic tone, you get more sleep and you get a clear brain and a rested, rejuvenated body. It reconnects you, okay? And you adapt it anytime you need. Difficulty with focus and memory with insomnia. Of course, when you have that more solid sleep with breath work, you're not going to have that problem with focus and memory. And then persistent worries about sleep. So persistent worries about sleep is for future related. So this is about what'll happen if this happens again tomorrow. I can't be tired tomorrow. Breath work brings you back right here, right now. It takes you out of future anxiety related thought and brings you into calm, present moment. So what is breath work? Structured, intentional breathing exercises or techniques that aim to improve physical and mental well-being, and it's always present moment. This is an example of all the different breathwork techniques that are out there. Diaphragmatic is typically the basis of most of them. We use pursed lip breathing a lot with people with chronic obstructive pulmonary disease, and then also with anxiety, because it allows us to extend the exhale time. The slower the breath rate, the better the effect. I'll go into that in a moment. Pranayama breathing, yogic breathing, it is a specific movement of the air in through the nose and out through the mouth, or in through one side of the nose and out through the other side. And this is actually using the mechanoreceptors in the nose in a really brilliant way. So diaphragmatic breathing, I don't think we appreciate how much diaphragmatic breathing does for us, but it is literally the backbone of breathwork techniques. What happens when the diaphragm comes down and it is flat in the breath in a full inhale is we get a stimulation of the vagus nerve and an activation of that parasympathetic nervous system. So we massage that vagus nerve that runs right through the diaphragm, and it calms you. We get an increased stroke volume, and we get an increased tidal volume, which trigger a decrease in the sympathetic nervous system. So the reason why we get that that stroke volume, that increased stroke volume, and that increased tidal volume is because when you get more the best lung recruitment to the lowest lobes of the lung are tied directly into the parasympathetic nervous system. So if we're stimulating the parasympathetic nervous system, it automatically takes the gas off the SNS, or the sympathetic nervous system. And then all of these things increase heart rate variability, which improves long-term outcome. Incredible. So the power of breath, this is a beautiful document that is put out by Veterans Affairs, and what they do, it's a tool, it's a whole health tool, and it's made for people who help veterans. It's basically to help add to their self-management toolbox. So, and with practice, like they say, most clinicians can teach it to their patients in 5 to 10 minutes. So I really encourage you, if you do work with people with veterans and war-related trauma, that this would be a really interesting tool to pick up. So how breath control can change your life. So basically, when we look at breath control, it's a breath control of 6 breaths a minute. So when we look back at one of those breathing techniques, the 4, 7, 8 breath technique, that brings us to a 6 breath a minute rate. So when you go down to 6 breaths a minute, we have a voluntary regulation of internal body state. So it's this inner awareness, this interoception that happens. And the other is associated with the role of mechanoreceptors. Now, those mechanoreceptors we're talking about in the nasal cavity. So that's what is engaged in the pranayama breathing, or the yogic breathing. Short-term versus long-term slow breathing. So as short-term, of course, we reduce our oxygen consumption, our heart rate, and our blood pressure. We increase the amplitude of theta and delta waves. This, to me, was incredible. I did not know this until I researched it. But this indicates predominant parasympathetic tone. So if we have somebody in theta and delta waves in wake brain activity, and they are showing us theta and delta waves, we know we're in parasympathetic tone. It's quite brilliant. Decreasing the parasympathetic or sympathetic activity, and it improves the sympathovagal balance, or the balance between the sympathetic and the parasympathetic nervous systems. In the long term, we are reducing the risk of developing coronary vascular disease and type 2 diabetes mellitus, and that's the endothelial function. And I think Terrence has couple of really good lectures on endothelial cell dysfunction, which is one of my interests as well, actually, and how it relates with people with sleep related breathing disorders. And it also improves pulmonary function, so our reserve volume and our dead space ventilation, of course, with recruiting the whole lung. This was a systematic review, and they acknowledge in this systematic review that there wasn't a bigger sort of look at studies that they wanted to have. It wasn't a methodological quality of included studies that they could have had, but it's what was on hand at the time. What they did find is that there was great heterogeneity on these studies, which showed that it just had this broader application that was quite possible here. So promising that it has a positive impact on cardiovascular and respiratory functions and improves the autonomic system towards our parasympathetic. Now, if we do that, we are fostering that shift between wake and sleep. So What is our long-term strategy? We want to create the world that you wish to live in. Look at what works for you. Things like hypnosis, meditation, mindfulness can facilitate eases of consciousness shift. So what you practice during the day is what you will also get during the night. And calm states, when we become more familiar with calm states during the day, in between those things, even if you get flashbacks, even if you get intrusive memories, when you are calm in between and you are taking control back in those times, they become familiar and you become more confident that you can regain that. And then understanding what normal sleep looks like for you. You're not the average person, you are an individual. And removing the barriers to sleep, taking the chocolate bar out of your hand as you're getting into bed, and then adding supports to your sleep in the area that you value most. And then, of course, that one small change a week with your goal, and stick with it. Let it show you it can work with time. You didn't fix Rome in a day. So just in summary, PTSD, it's a trauma and stressor related disorder. It impacts the sleep through actual brain changes, but treatment is often through qualified healthcare practitioners who practice that cognitive behavioral therapy, and it can be quite successful. I didn't see a lot of outcome studies, but the CBTI is a very effective tool for most insomnia-related disorders, and insomnia being the primary key feature of PTSD. And then, of course, medications are there as well to be used as a complementary piece to either support short or long term. Typically, where we see medications used is at the beginning, where we try and kind of stabilize people a little bit with as we get the cognitive piece online. And here's my references. Thank you very much.